Hello, everybody. Let's take a look at the essential information that will help you understand thyroid gland diseases and logically explain the diagnostic and treatment procedures. From the physiology, we need to know that the activity of the thyroid gland is primarily regulated by hypothalamus, produce TRH, thyrotropin releasing hormone. It stimulates the anterior pituitary to release thyroid stimulating hormone. TSH is the main regulator, stimulates producing and secreting the peripheral hormones triiodothyronin, T3, and thyroxine, T4. T3 and T4 provide negative feedback to inhibit TRH and TSH release, maintaining hormonal balance. That means that in case of high T3 and T4 concentration, these hormones decrease or block secreting of TRH and TSH. As you can see from the name of the hormones, these are iodinated molecules of the amino acid tyrosine with 3 iodine molecules or with 4. How are hormones produced in the follicular tissue of the thyroid gland? In peripheral blood, TSH binds to its receptor, TSHR, on the membrane of thyroid follicular cells, which triggers the synthesis of thyroglobulin. Thyroglobulin is subsequently secreted into the colloid within the follicles by the enzyme thyroid peroxidase, TPO. Iodine binds to thyroglobulin with the formation of T3 and T4. The active form of thyroid hormone and T4 is storage form. T3 can enter the cell and subsequently the nucleus and can bound to specific DNA sequences called thyroid hormone response element, TRE, that resulting in transcription of the target gene into mRNA and next into specific proteins that function in metabolism glucose, proteins, and lipids. Thyroid hormones regulate hundreds of genes in various tissues and deeply affect fundamental metabolic processes. Thyroid disorders are associated clinically with either insufficient hormone production, hypothyroidism, or excessive hormone production, hyperthyroidism, presenting distinct symptoms. Hypothyroidism, characterized with low hormone level under the normal rate of 3 to 4, 12 to 22 p-mol per liter. Usually, 3 to 4 hormone is measured because it's more stable than 3T3. Hypothyroidism is often associated with a state of exhaustion and if the patient's batteries have run out. Clinical symptoms related with carbohydrate metabolism is low energy, somnolence, decreased glucose metabolism and glucose tolerance, constipation due to slow metabolism and intestinal hypomotility. 10 metabolism disorders are reduced protein utilization and synthesis, leading to muscle weakness, myopathy, slowed protein degradation, which may result in myxedema. Myxedema is accumulating of mucopolysaccharides in the subcutaneous layer with water binding. And lipid metabolism disorders is reduced lipid utilization, dyslipidemia, which increase cardiovascular risk, and the development of atherosclerosis. Typical symptoms of hypothyroidism are deepening of voice, puffy face, hair loss, myxedema, overweight, bradycardia and low blood pressure, and microcytic anemia. Hyperthyroidism, there are opposite symptoms associated with so-called increased activation of metabolism or high battery level. Carbohydrate metabolism disorders that are increased gluconeogenesis, accelerated metabolism, worse sleeping, increased appetite, frequent diarrhea by increasing intestinal peristaltis. 10 metabolism disorders are high utilization, muscle weakness, and sarcopenia, muscle tremors. Lipid metabolism disorders, high utilization and loss of adipose tissue, and weight loss. These metabolic changes correspond to the typical clinical symptoms of hyperthyroidism, such as nervousness, often protruding eyes due to autoimmune inflammation of retrobulbar adipose tissue, hair loss, sarcopenia, weight loss, tachycardia, till atrial fibrillation, and high blood pressure. And what about goiter, struma? It's a visible enlargement of the gland, but it does not explain the functional state. It could be hyperthyroidism or hypothyroidism, and therefore I don't consider it a typical symptoms of any of these diseases. Diagnostics. In the case of hypothyroidism, the concentration of peripheral hormones is reduced, and according to negative feedback, TSH will be high. Conversely, in the case of hyperthyroidism and increased concentration of peripheral hormones, TSH levels will be low. In this case, however, it's a thyroid disorder that is a peripheral cause. In central hypothyroidism, a disorder of the hypothalamus or pituitary gland is associated with low function and reduced secretion of TRH and TSH hormones, which logically leads to reduced secretion of T3 and T4. In central hyperthyroidism, there will be high secretion of TRH and TSH and therefore high production of T3 and T4. Common causes of central hypothalamic and pituitary disorders are trauma and tumors, which then increase or decrease the secretion of central hormones. Etiology of peripheral thyroid disorders. The most common causes are autoimmune thyroid inflammations, where the immune system attacks thyroid cells. In autoimmune hypothyroidism, also known as Hashimoto's disease, we can determine antibodies to internal structures of thyroid tissues, anti-thyroglobulin and anti-TPO antibodies, those that indicate internal deep damage. In autoimmune hyperthyroidism, also known as Graves' disease, we can determine antibodies to external structures of thyroid tissue for anti-TSH receptor, those that indicate external stimulation. Iodine is essential for thyroid hormone synthesis. Deficiency can cause goiter and functional disorders. Excess iodine may also impair thyroid function. Thyroid tumors can be benign, most commonly follicular adenoma, or malignant, various types of carcinomas. The Bethesda classification distinguishes between these types of tumors from stage 1 to stage 6. 6 is the worst type of malignant tumor. It can cause local problem or alter hormone production. Interestingly, some medications like amiodarone and lithium cause also glandular disorders. Therapy. In case of hypofunction and lower concentration of peripheral hormones, it's very important to provide appropriate substitution. This can be done with levothyroxine medication, starting with a low concentration, for example, 25 micrograms per day, and gradually increase it. In the case of hyperfunction, thyrostatic treatment is necessary, where the typical medication is propylthiouracil, which blocks the function of TPO, and other medication in this group block the synthesis of T4. Here we start with higher doses. It's also advisable to supplement with vitamin B6 to support DNA synthesis. So, that's all basic but essential information you need to know about thyroid disorders. It would be also useful to watch next short videos, especially about hypothyroidism and hyperthyroidism, to reinforce this information in your memory. Remember, understanding and repetition are the keys to success. Thank you for your attention and good luck.